Good morning, good afternoon, good evening. Thank you all for streaming in live today for our webinar, for the malnutrition webinar that we've organized. So first, I would like to thank you all for joining us and for being interested in this topic for one. So I'll start with one. I will start by letting you know that you can have conversations with us, use the chat, the YouTube chat for you to ask us any questions, or maybe if you want to add into the discussion, feel free to put your comments on. And just to start with the introductions, my name is Lili-Marie. I work with MSF as a communications manager for Kenya. And I will introduce to you my colleagues that we are together with in the chat. But before then, I will just want to let you know of who we are. So MSF is MSF, also known as Médecins Sans Frontières, or Doctors Without Borders, is an international independent medical humanitarian organization that delivers emergency aid to people affected by armed conflict, epidemics, exclusion from healthcare, and natural disasters. And we are in more than 70 countries around the world. So to kick it off, first, I would like to apologize. As you saw in the poster, we had Dr. Mohammed, and he's not available to be with us today. Since he's currently working on an emergency response following the escalation of clashes in Sudan. However, we still have very great experts who have been in the project that MSF supports, and I will introduce them one by one, and you'll hear more from them as we continue. So first, I'll introduce Lili-Marie Wangari. Wangari has worked for MSF since 2010 and is in Kenya. She focuses on non-communicable diseases and emergencies, as well as MSF's regular projects in the country. She's currently working as a deputy medical coordinator and is based in Nairobi, Kenya. On the other hand, we have Dana Krause. She joined MSF since 2006 and has worked in multiple countries, including Kenya, South Sudan, Haiti, Nigeria, and Syria. She is currently the organization's country representative in Somalia. So I hope we can hear us clearly. Give us feedback if you cannot get our voices clearly. And with that introduction, we'll start off. So just to start it out, I know normally you hear about malnutrition. What is malnutrition? What is it about? So I'll just ask Wangari, what is the difference between hunger and malnutrition?
Hello, everyone, and thank you, Lucy, for that brief introduction. As Lucy has shared, we hope this webinar will be able to allow you to understand how we as MSF work, but also what could be the needs, not only in Kenya, but within the region, linked to malnutrition. Lucy has asked a very interesting question. And why I say it's a very interesting question is because now I'm hungry, and because I missed my lunch. So hunger, in simple terms, would be defined as lack of food. So you lack food for one reason or another. If you continue to lack food, then something could happen in the long run. So it could be that if I am a young child, a child who is between the ages of maybe, let's say 6 months to 5 years, and I consistently lack food, then it will have an effect on my health. So what would be this effect? It means that I don't get what I require, so the necessary nutrients that allow me to have proper growth, that allow me to develop. So I'm sure some of you have met children who you think, oh, that child is short for their age. Or you think, oh my, that child is a little thin, too thin for either their height or for their age. So in a nutshell, that is what we would consider as malnutrition. It means that you don't get the necessary requirements, so the nutrients or what is required in your food, for you to be able to grow. And what's most important is in the ages where development is taking place. And for various reasons, this happens. Maybe we are not able to get food because of our socioeconomic status. So the food that's available to us is what fits our pocket. It could be that as a child, I'm always sick. So I have recurrent diseases, I have diarrhea, and because of that, the nutrients that I need to take in do not remain in my body, and I then end up having malnutrition. Now you know that it's raining, and sometimes when it's raining, the quality of the water that we may have may not be what is good for us to drink. So in some of the places where we work as MSF, the quality of water is not adequate. And with the current drought, so what is drought? It means that you have a prolonged period where it's dry. Then the people in the community don't get water that is clean. Or if they're able to get water, then it's not to the quantity or sufficient to meet their needs. So Lucy, I hope I have answered your question that yes, hunger is when you lack food, but then in the long run, if you're not able to get the requirements in your diet, then you will have malnutrition.
Yeah, so I think that's maybe just to follow up a bit on the malnutrition also. As most of the time when we talk about malnutrition, we speak on severe acute malnutrition, moderate malnutrition. Please, can you differentiate these types of malnutrition? Maybe Wangari.
As I shared, the malnutrition, one of the ways when we talk about malnutrition is we talk about undernutrition. So that's one form of malnutrition. Maybe what you don't know is that obesity is also considered a form of malnutrition. However, for purposes of this webinar, we'll talk about undernutrition. So undernutrition means that either you have your weight is low for your age, or you're too thin for your height or for your age, or it could be a combination of both. And what usually happens is that when you go, you know how we have the clinics. So when you get a baby, there are the routine clinics that the children should go to. So it's in these routine clinics that measurements are done. So what is the measurement? You need to take the weight of the child, you need to take the height of the child, and then you need to look and see if baby Lucy is 6 months, how heavy should baby Lucy be? How tall should baby Lucy be? So these are some of the markers that we use within a health facility. But also within the community, we do similar things. So when I say similar, it means that there are places where you could take care to the community. So as MSF, that's one of the things that we do. We not only work within a hospital or a health facility, for example, a health center, but we also go to communities because that's what our mandate is, to increase access for communities. So while we are in the community, we will take the weight of the child, we'll take the height of the child, but we could also measure the upper arm. And when we measure the upper arm, then we are able to see whether this child fits into what is, yes, exactly. So this is a child who we are measuring to understand, are they fitting within the normal parameters that are expected for their age? If that parameter goes below a certain level, then we will begin to say that this child could be having what is called moderate acute malnutrition or severe acute malnutrition. But it's not only the measurement that we look at, we also look at the child in totality. So this is a child who you'll notice is very thin. For some of them, if you expose them, you'll notice you can see the bones. It's pretty obvious. Some of them will develop some skin conditions because they are not getting the necessary nutrients that they require within their diet.
Thank you, Wangari, for that elaborate explanation. So maybe to ask you from the Somalia end, Dana, what is the current situation that we see in Somalia, and what are the reasons for the malnutrition that we are witnessing in Somalia?
Thank you, Lucy, and hello, everybody online. So moving to Somalia, a lot of things that Wangari mentioned, we also see on the other side of the border. So as many of you know, conflict has been ongoing in Somalia for many, many, many years. But also, as the situation is in Kenya in regards to the drought, we exactly see the same situation in Somalia. So what we have at this point in time is the 5th consecutive rainy season that has not been, well, as good, I suppose, as we all had hoped for. So it's ongoing as we speak. The situation is slightly better than it was a couple of months ago. Nevertheless, you have you have several factors playing into the current situation. So you have a conflict, you have the impact of the drought, you also have the impact of the climate change at large, which then drives the food insecurity, displaces populations. And of course, we are also talking about a country where access to healthcare is very, very difficult. And then on top of everything else, like in any rainy season, now our teams are also dealing with flash floods in some of the locations where we're working at. And then again, this is a cycle that leads to an increase in infectious diseases. So I think we also have a map of Somalia. So if you can put that up, and I can explain you a bit for specific locations what the teams have reported back to us in the last couple of days. But yeah, it is not just one driver. It's tenfold. There's many aspects that influence the current situation in Somalia and the current response of the MSF teams on the ground.
Yeah, so maybe we'll wait for the team to maybe put up the map of Somalia.
Yeah, and perhaps, I mean, maybe just to give you a snapshot, I mean, you will see when the map is up that our teams are working in several locations in the country. All locations provide nutrition activities, both ambulatory in the community, but also in the hospital. And maybe to give you the latest example of our rapid screening in Jubaland, which is the area that is bordering Kenya. We had a team that just returned, and basically of all the under 5 years of age children screened, almost 50% of them were malnourished, so either severely malnourished or moderately malnourished. So we are facing a big nutrition crisis in many of the areas where we're working at, and you see on the map the specific locations. And the situation is like this pretty much across the board. So with the contextual elements and the drought elements, MSF teams try and respond as much as we can to the ongoing malnutrition crisis in Somalia.
Wow, it's a very heavy thing. It's a very grim picture. And actually, currently we are witnessing the worst drought in 40 years in the Horn of Africa. So that already reflects why we are having all this also happening on the other sides of the different countries and different regions. So
exactly.
We'll introduce, or we'll view a video from one of our doctors in Somalia to just give us an aspect or a perspective on what's happening in the country. So in a minute or so, or in some seconds, we should listen in on the video by Dr. Asma Awis.
We are seeing in our facilities patients with different needs, with infectious diseases, with malnutrition, with cholera. So we are responding to many different basic health issues that the community now are facing. I remember that we admitted a mother and her child. The child is admitted into the ITFC program in Bay Regional Hospital with malnutrition, and the mother is admitted in our pediatric with measles. So the child died 2 days after the admission, and the mother also died in our facility 1 day after her child's death. It was a tragedy to the whole family that were 4 when they came and lost 2 of them, and because of measles and malnutrition needs. The most striking part of treating or running this malnutrition response is that when you see 900 plus cases in a week, and also find that 80% of them are admitted to the program. This really tells you the level of the malnutrition in the community, especially in the children. And it tells you also how the population are suffering from food insecurity and the drought as well.
Oh, thank you for that. This is just a grim picture. And for sure, as Dr. Asma has also mentioned, it's not only affecting children, but it's also affecting also mothers. So Wangari, please share with us a little about the project in Kenya and some of the causes of malnutrition that you have observed or witnessed.
Thank you, Lucy. I think it was interesting to listen to Dana, and I was actually shaking my head as she was talking, because I felt like she was describing our work here in Kenya. And it's interesting that though she's talking about Somalia, you get a sense that the population in Kenya is facing similar challenges, linked to the drought. So where were we working? We were working in Marsabit County. Marsabit County borders Kenya and Ethiopia. It's actually the cradle of mankind. And it's one of those places where you visit and you marvel at the resilience of the community. And why do I say the resilience of the community? This is a community because of the effects of drought. So yes, as Somalia, they've had 5th failed rain. So this year is projected to be the 6th failed rain season. And what was striking was the number of animals that had died. So for a population that is, or a community that is defined by an asset, so the assets being the animals that they have, the cattle that they have, you could clearly see that this drought and the impact is different from the previous years. And it paints a picture of how difficult it is for them to just be able to cope with their lives on a daily basis. And of course, if you are relying on your livestock, for example, for milk, so this is where you get your milk for your children, then if you do not have that asset, it then further reduces your ability as a family to actually provide what would be the necessary basic, because I would consider that this would be the basic food for your younger children. In some of these places, you realize that because of the tough situation, then families tend to have children getting married at a younger age, because it also helps the family socio-economically, because there will be an exchange of assets. So when you have young mothers who don't understand about how to feed their children, then in the end, the children will end up having malnutrition. Of course, it's dry. So when it's dry, access to water is an issue. And as a result of that, the quality of the water that they would get as a family would not be good, would not be what we would consider clean or fit for drinking. And so that further exposes them to diseases like diarrhea. These are places where, of course, Dan has mentioned, it's raining. It's raining now in Kenya, and maybe many of you are wondering now, why are we talking about drought? And almost every day we see about flooding, we see about rains in many parts of the country. This week, I think the meteorological department shared a nice map which showed different parts of the country where it's supposed to rain, and it continues to rain. But the reality is there is flooding. So if you have flooding in an area, it further cuts off this population from access. So access to what? It means that if we were to provide food, so they transport the food, because these are not people who are having farms. So if they need to transport food from other parts of the country, it's not as simple as waking up today and tomorrow the food is in that part of the country. So contextually, then you have other drivers. limited varieties, you have limited purchasing power for them to be able to get the right types of food, depletion of their own assets, and then practices. So young mothers who are not very conversant in terms of what they need to do. And then when you have health structures that are could be considered, weak for whatever reason, and then patients are not able to access the care that they would need from those health structures, then of course it will have an impact on how I feed my child, how I get treatment. So within Marsabit County, that is exactly what we found. We found a population that was trying to cope. We found a population that had now reduced. So within the homes, how are they coping? It meant you go without food, so you sleep hungry. And even when you had access to some money, you are also limited in terms of what you could buy within that context. And the picture isn't different now. Our intervention ended in December, but it's not different now. Just because it's raining doesn't mean that we are going to have the impact today. It will take some time for the community to be able to then regenerate, replenish the resources. So we hope it continues to rain, because then it will be good for them. But in the interim, we still expect to see children with malnutrition. Recently, the Ministry of Health and other actors on the ground actually did a screening in the community. And, you find that 50% of the children, so what is 50%? It means if you have 10 children who you take measurements, 5 of them will have malnutrition. And that's despite the fact that people are saying, yay, it's raining in Kenya. So we won't feel the effects immediately. But if it continues in that trend, then there will be changes. But for now, we still have children with malnutrition. We still have families that are coping. And by coping, I mean they're missing meals just for them to be able to manage the situation as it is.
Wow. So the situation seems to be interrelated with so many aspects of life, from livelihood to rainfall to having crops to access to food and all that. Then why does MSF particularly consider this a health crisis? Why is malnutrition just not another issue that government should work on? Why is it just specifically a health crisis then? Yeah, maybe Dana, you can take up, or Wangari, you can start. Yeah.
I think for me,
Wangari, please go ahead.
Yeah.
I'll pitch in after.
I think for me, it's the fact that when you have malnutrition, you're more at risk. So out of all your children, if you have children who have malnutrition, they're more at risk of getting other diseases. So other diseases could be measles, or they're at risk of dying. And already these are areas that are struggling with shocks from the prolonged drought, infrastructurally. So you have health systems that are not able to cope. So it's not only malnutrition, you will have cholera. I think Dana has talked about cholera. You have measles. So you have other diseases that are already straining the healthcare systems in these areas. And for me, I feel that is what would make it worse or further compound the situation for children who have malnutrition.
Yeah. Please take it up, Dana, if you have anything to add.
Yes, perhaps just to add from a Somalia perspective. So what I mentioned earlier was also the internal displacement of a high number of populations across the country. So for example, as Wangari explained, if you have malnourished children in your family and then you're displaced, you're on the move, and already prices are high and you have very little income that you can generate. And then you finally find a place where you can stay and settle with your family. You are living in very overcrowded conditions, which is also something where you start sharing the little that you have with all your family members and probably the community at large. So this is also then feeding into the cycle of malnutrition not being a standalone topic, but really being a topic of being part of a bigger crisis, a bigger medical and humanitarian crisis. So you have access to healthcare that is very often compromised, access to preventive and curative activities, access to vaccinations, for example, and just normal screening activities. And then you have also a community that's at large, doesn't have access to food, to clean water. So one factor, you know, feeds into the other, which is also why we see the number of children that are screened severely and moderately malnourished. And that's why it's also not one rain, as Wangari said, that will solve the problem. Hopefully, we will see an improvement over the coming months. But right now, we have to deal with what our teams see on the ground right now, and hopefully be able to scale up and respond to this.
Wow, yeah, thank you for that. I think it's clearly coming out that it's a cycle, not of one starter or one end. Yeah, it's just like a cycle. And that brings me to ask, so what are some of the activities that MSF is currently doing to fight malnutrition? And how does MSF treat malnutrition? Dana, you can start us off here.
So I will, let me speak a bit about the programming. So what we do on our side. So of course, when we see the screening data, as I have presented, for example, from our Jubaland teams, what we are aiming to do first is increase the number of screening events that we do, either in community, at the health facility, together with the Ministry of Health. We'll look at the data, and of course, then there is several options what you can do. You can go and expand your programs into the community to reach as many children and pregnant women as possible. And then, of course, also you have to look at how to increase bed capacity, because many of the severely acute malnourished children are the ones who require intensive care. This is not something where you just admit a child and feed a child. This is a very, very not difficult. It's a very complex medical treatment. So we consider it an intensive care treatment. So for this to happen, the child needs to be admitted in a health facility. So we need to increase beds in order to be able to respond to the demand and provide this quality of care for severely malnourished children as well. And then, of course, there is the famous plumpy nut that many of you have probably heard about. So we call it the ready-to-use therapeutic food. So we need to have the supplies as well for this to be able to respond both on community level but also on health facility level. And to also keep in mind for the audience that this is, if you admit a malnourished child into a program, no matter if it's in the community or in the facility, this is not a 2 weeks treatment. This is over several weeks. Very often, you know, it first gets worse from my own experience before children finally get better and recover. So this is also not just like a 2 weeks response and then everything is back to normal. But probably Wangari can also explain a bit more from the Kenya perspective what we're doing in Kenya. Wangari,
thank you, Dili. I like what you said. I like the fact that you said that we need to go out into the community. And while we were in Marsabit, so what were we doing as MSF in Marsabit? So we had a community component, what we would call an outreach activity, where you go into the community, as Dana has said, you screen the children. Those who are sick, you treat them. And then you, of course, give them either medicine for their sickness or give them the nutritional commodities, which is the plumpy nut that she's talked about. And then the second thing is that those who are too sick to go back home, you need to have them in an inpatient facility where they are monitored, supervised in terms of the feeding. You treat other medical conditions that may prevent them from taking whatever medications you would ordinarily have given them in the home. And because of that activity, we were actually able to get, so we had 134 children admitted in our ward. But out of the 134, 117 we actually picked from the community outreach activity. So that clearly tells you that if you stay in a hospital or a health structure and wait for patients to come to you, the most vulnerable will not reach you. So it's always important, and I like this picture. This is our ward where we were collaborating with the Ministry of Health. And And so it further tells you that the lower you go, you will get more people. You will get them early. And so those that you catch early, you can prevent complications. From screening within the community, we were able to get an additional 1,341 children that we enrolled into the nutrition program. So a combination of factors will help you to get to where you need to go, will help to improve, the condition of the children and the pregnant women within the community, but it's not enough. And why I say it's not enough is because many organizations that are running these activities are facing funding gaps. So there is the reality of it's not only in Kenya, it's Somalia and many other parts of the world that have malnutrition. So MSF is not only in Kenya, MSF is in Somalia. We are in other parts of the world. So how do we manage with the number of children with malnutrition? How do we manage with the other diseases, the outbreaks, the displacement? In Marsabit, we had displacement because of the flooding. They are part of the community that you are providing service to. But having said that, not all is lost. Even with the little that we are doing, with the little that's being done by everybody, there are still those whose lives will be impacted, will be changed because we went out into the community and found the children. We admitted those that we needed to admit. And so we improved their quality of life. And we hope that this can continue even for this period where the drought, we are not out of the woods yet in terms of the drought situation. So we hope that this can continue to happen.
Yeah, from both the explanations, it comes out clearly that it's not only organizations giving support, but it also means that the community members are as much involved in the response when it comes to malnutrition. Because when you speak about outreaches, the communities should be accepting of the fact that, yes, we want to bring our children for these outreaches for them to get the support. And just to go back to the online family, thank you for sending your questions. I am glad that we are seeing your questions for sure. And the first question that I'll maybe also ask that is connected to what Wangari and then I've just talked about, it's on what are some of the challenges that you're facing. One, I'll start with Somalia when it comes to the response. Yeah.
I mean, the challenges are, it's a very valid question, and the challenges are many. I think first and foremost, it's accessing the population. So it is, as I mentioned earlier, when I introduced Somalia and the current context, it's a very insecure country. So it is very, very difficult to reach the so-called hard-to-reach populations. So we work together with the Ministry of Health in all the locations where we're currently operating, where our team is on the ground. But yeah, there is the topic of security and insecurity, but even so, even worse than that, it's just the sheer scale of the needs that our teams are seeing on an everyday basis. I mean, as I said, you screen a certain community and 50% of the children are malnourished. It's absolutely, I mean, it's devastating both for the people on the ground, but also for the teams when they see the situation during their rapid assessments. So for us, if I would have to choose two major challenges that have not so much to do with the capacity of other agencies, it's really that. It's access to the population and the sheer scope of the emergency that our teams see on the ground.
Wow, for us, here in Kenya, what were the challenges? I think it was similar. Yeah. We had, you screen 10 children, 5, 7 need to be enrolled. But malnutrition is not only a medical component. You need the food security. So you need to add on so that as you give treatment, the plum peanut, as you give other medicines, there is also food accompanying. But the realities of the magnitude of the problems on the ground is what faces you. And we were not able to meet all the needs that are on the ground. The other actors who are there were also not able to meet the needs that were on the ground. Water was a challenge. I think it was one of the places that I have worked in where the reality of actually not finding water that you can drink, and it was not only for the population, it was the same for MSF. So you realize priority. If a mother wakes up in the morning, what is her priority? It's water, it's food. So their priorities are different from what I would see as a priority for the community. In some of these places, conflict with neighboring communities. So, further pushing them away from areas where resources for their own livelihood, so for their animals. And then outbreaks. We had a measles outbreak. So how do you manage? There's a measles outbreak, you have malnutrition, and so the partners are the same. You're not getting new people feeding into the picture. So how far do you go to be able to manage the situation that was at hand? So just like Dana said, then what do you choose? I mean, it's the reality. What do you choose? It's the community you're working in, it's the community you're serving, and you want to give everything. But the needs are more than what we would be able to manage.
That's quite interesting. And maybe just to link it to that, maybe Wangari, you can take us through what happens. I know Dana touched on it, and also you've touched on it before. What happens immediately a child comes to the hospital? Let's say a child is found to be malnourished. Just take us through the type of care from the start of the care, what is involved in such. I know Dana mentioned even the plum peanuts, but you can maybe take us through it. And also you can link it to a question that has been asked from the audience. Are you also screening mothers for malnutrition, especially pregnant and lactating mothers? Since under 6 months, malnutrition is mostly linked to mothers' malnutrition and breastfeeding issues. So maybe you can give us also a perspective of how is this also captured while treatment is being given.
All right. The nutrition program, how it works, at least here in Kenya, is that we not only screen children, we screen pregnant and lactating women. So whether you're providing a service in the community or you're providing it in a health facility, the activities are the same. So what are these activities? It means that when they come for a clinic, because even in the community, you will have clinic days. So you will ask them to come back on a certain day when you know you will be available to provide a service. And then in the health post, they're able to come to a health center, for example, they can come to the health facility because health facilities open daily. So when they come, you will take measurements because measurements are what will guide you in terms of even who to put in the program, who is likely, so who is at risk of developing malnutrition. So you need to provide the right information to prevent them from now being enrolled into a nutrition program. And it will also guide you to say that your child or the pregnant and lactating mother is improving, her health is improving, and allow you then to finally say that now we will take you out of the program. So we will take your weight, we will take your height, but additionally, we will also screen. So screen for, are you unwell? If you're not unwell, if it is a first visit, there is the routine medication that needs to be provided. So that medication is given to the children. There is the routine medication that is given to pregnant women. So as part of the antenatal follow-up, there is the routine that's given to the lactating women. So plus education. So we'll educate them. If you're pregnant, what do you need to do? If you're breastfeeding, so a lactating mother is a breastfeeding mother, this is what you need to do. Continue breastfeeding, etc. In that visit, if you have sick children, then you will treat them. If they have diarrhea, you treat them for diarrhea. If they have an infection in the chest, you will treat them for that infection. And then you will give an education. So in those, during that time, we take opportunities to educate. So in the health facility, you will find that there's a health talk that's being given. In the community, we will also give them a health talk. Why? Because you also want them to adhere. You want them to continue doing what is required. So if you've given them medication because they are unwell, you want them to complete the medication. You want them to take it correctly. If it is the medication for malnutrition, so what is this medication? So there is what is called Plumpinat, and that is for children who have severe acute malnutrition. Then there's Plumpisat for children with moderate acute malnutrition. And this is just like a preparation that has the required nutrients for the child. So based on the weight of the child, then we are able to determine, maybe as baby Lucy, you need to go home with 2, or you need to take 2 every day. So it's during those sessions that we clearly explain to the mothers or the caregivers that this is how you need to give the medication. But before we discharge them, we also observe, because not all children are the same. So we observe them to see if I give you medication, so the nutritional commodity, for example, will the child be able to take the commodity as we have prescribed? So then we observe, and then we say, okay, this is a child who can go home, and under the supervision of a caregiver, then they should be able to provide all the medication that has been provided during that particular visit. And then, of course, we tell them, if the child is still unwell, if the pregnant or lactating mother is still unwell, they need to come back to the health facility. So not wait. What is not wait? Most of these clinics run every 2 weeks. So when we go to the community, the activity is running twice a month. And that means that in between, if you feel unwell, then you should go to the nearest health facility so that you can get treatment. So I think in a nutshell, that's what's done during those visits or activities.
Yeah, just out of curiosity, when we talk about medical care and people coming to the health center or the health care facility to receive care, the assumption is that the communities are okay with coming to get health care. So maybe just out of curiosity, is this the case? Do the communities normally are they normally more accepting of coming to get healthcare? And what will be the message to them for sure if such is happening and there is a facility? Before I come back to Dela to give us more context on Somalia.
I think the realities of how the health structures are, to me, is what can sometimes determine. I may be willing, but the health post is 40 kilometers away. So I'm faced with that reality. Some of the places that we went for the community outreach activities were as far as 35 kilometers away from the health post. So even if a mother wanted to come, a mother who's pregnant or a mother with a child, it's quite a distance. I don't think, Lucy, you and I can walk 40 kilometers, but we expect that communities should be able to walk 40 kilometers. So access issues also further reduce how communities are able to access health facilities. And so for me, I think it's one of the ways that, governments or Ministry of Health should reflect about, that even when they put up health structures, how can they further improve access for the communities that they are working in, the communities that they themselves want to serve and want to reach. And it's even worse when it rains, because this means that the road gets cut off. And even we sometimes fail to go for outreach activities because of, the bridge is washed off, the road is washed off, there's a big river, a seasonal river in between that's overflowing. So there are always contextual challenges that, prevent people from wanting to or reaching a health facility.
Yeah. So maybe, Dana, there's two questions on Somalia that I think will be interesting to hear. I know you've mentioned one. Does MSF have a stabilization center in Somalia? As you also chime in on that, and also Yeah, you can just mention where the areas that we are supporting, we are giving this malnutrition response in.
Well, basically, we provide the nutrition response in all the locations that you've seen on the map earlier. So there is our permanent projects in various locations in the country. And then we also have a bit more of an emergency focused team that is mainly working in Jubaland. And they're currently focusing in Doble, but they've also worked in other areas. And there, of course, the malnutrition crisis is very obvious just looking at the data and looking at what our teams are presenting to us when they come back. So there you see where the teams are based. So we have a very, very big program in Baidoa. We're currently trying to upscale in Doble, which is in Jubaland. We also have a big nutrition component in Galkayo North and South, and also in Lassanot. We continue, despite the current ongoing violence, we continue with the nutrition screening and also with enrollment of children and pregnant or lactating mothers in the various IDP settlements following the latest outbreak of violence. But yeah, maybe just to pick up on what Wangari said in terms of access, of course, accessing services is also one of the big critical points in Somalia. And what we also hear very, very often from the mothers is that, there's more than just one child in the majority of the families. So also very often mothers need to make a choice. If they focus on the sick child and go with the sick child to a health facility or even to a hospital if the child needs to be admitted, and then also arranging who is taking care of the other children in the family. And of course, this is very, very difficult. And I'm sure Wangari has seen this many, many times in Kenya as well. But this is also something where our health promotion teams and our community teams really need to emphasize with the community, with the mothers, on a daily basis, why it is important to come, especially if the child is not getting better. And this is again competing priorities, and we also have to understand as healthcare workers that we cannot push somebody because there is also a larger family in the picture and many more children and many more aspects in each and every individual patient story.
Thank you for painting that picture, Dana, on some of the complexities that the population also face or the people face. So this brings me to ask then, what is MSF really asking for? What is the needed change or change that is needed for this situation to stop? Maybe, I don't know, one of you can take it up, either Dana or Wangari. What do you propose? What would be the solution?
Shall I start, Wangari? Let me start because, we are talking about this, of course, a lot as well. And I think we mentioned it a couple of times already. The response needs to be scaled up, and we are not just talking about Somalia or Kenya. We're talking about the entire region. We're in a crisis situation, so the response needs to scale up. And of course, a response costs money for each and every actor to be able to do their part. And we all know how the humanitarian funding situation is at this moment. Priorities are elsewhere. Priorities are not in the region. So what we are calling for is an increase in humanitarian funding, an increase in really programming on the ground, both on community grassroots level, but also all the way up the referral links that we have described, from the health facility to the inpatient stabilization centers. And then, of course, as we also said before, it's not just malnutrition treatment. There is a whole, package around it. We are also talking about access to healthcare. We're talking about access to screening services. We're talking about pregnant women. We're talking about small children. So it's not just a one-size-fits-all model. And personally, what strikes me the most about the current situation is that we've been talking about this for 2 years. So the situation was known that if the rains fail, the situation will only worsen, the crisis will only worsen. So everybody knew this. Nevertheless, the current response is running as we know it, as we described to everyone. So there's also really a responsibility for all the various donors and all the various international and local agencies to, try and rectify the situation, scale up the response, and should the drought situation continue and therefore the malnutrition crisis, to be able to respond in a better way and reach as many patients as we can reach.
Wow. So it has to be multidisciplinary. It can't only be agencies. It has to be government. It has to be the donors. So it's everyone's responsibility.
Everyone in the same boat. And of course, MSF cannot replace each and every organization because also our capacity is limited. So it's also, working together across sectors because it's not just medical, it's not just health, it's not just nutrition. And make this work and not turn it into a bureaucratic nightmare, but be very hands-on, very pragmatic, and release funding quickly and then implement on the ground. That would be our ask specifically for Somalia as well. Yeah.
Oh, that's a great ask. As we wait for Wangari to sort out some technical issue, I think it will also be good to hear from you. Someone has just asked, which main form of malnutrition do you see commonly in Somalia? So we had talked about the severe, moderate, acute malnutrition. So which ones do you see? Or
From what I've seen from the teams, there is very, very high rates in certain areas in the country of severe acute malnutrition, but also moderate acute malnutrition, which is basically the stage just before the patients deteriorate. And again, if you, as Wangari also explained, you have 10 children, you screen all of them and 5 of them get admitted in the program, is a very, very terrible situation to be in. And this is what we see, yes. And of course, should children be admitted in the hospital, in the stabilization centers, then they usually also come with medical complications, be it diarrheal diseases or respiratory tract infections. And that is, the trend goes in that direction. Yes.
Wow. Thank you. Thank you for this. To the online team, I'm seeing so many questions coming in. But before we go to the questions, I think we'll have some 5 minutes to respond to some of the questions that you've given, because I know most have also been answered by the panelists. So maybe to Wangari, we had left off at what is MSF asking for when it comes to this malnutrition? What can be done specifically for Kenya? And you can also merge it with a question that was asked on maybe you can start with the type of malnutrition that we see in Kenya mostly. Yeah, back to you, Wangari.
Thank you. So what do we see? We see moderate acute malnutrition, severe acute malnutrition. Actually, at the start of the intervention last year, we found when there were more children who were severely affected, what we would consider as having severe acute malnutrition. So they are more thin. Some of them will have swollen legs, what we call edema. You'll have skin changes for some of them. So the more severe it is, the worse off they look. Very thin. So you find a child who should be maybe 7 kilos is 3 kilos at 7 or 8 months or more. Maybe they should be 9 kilos. They are 3 kilos. But yes, so the forms that we do see when we have our activities, so when you're out in the community, in the health facility, is that you have children with moderate acute malnutrition or severe acute malnutrition. And then, of course, you'll have those who are underweight. So the younger children who are between 0 to 6 months, who will be extremely thin, for whatever reason. Wow, what can we ask for? We're still not where we should be. And we need resources. And the resources need to be able to support a comprehensive activity. So I would urge donors to, as they provide the resources, to provide resources that can include other aspects that they ordinarily would not include. So access to water, it has an impact because our children are having diarrhea. And so I wish they would include that, at least for this period, even if it's not what they would do. But for this period, to include other interventions which have impact on the outcomes for these children, on the outcomes for the pregnant and lactating women. So access to water, if you have outbreaks, ongoing outbreaks like measles, cholera, how do we include that so that we don't have children or pregnant women dying because they got cholera, or the children dying because they got measles? So for me, I would really urge donor agencies to consider including other aspects that they wouldn't ordinarily do. And then 2, food security. Yes, it's raining, but it's not enough. It's not enough for us to feel the impact at the household level. So how can we contextualize? And so when I say contextualize, go to an area and look at what is happening and see what else can we add on. Is it food we need to add on for this population, so that with these combined interventions, we can further improve the outcomes or the quality for the children who are enrolled in our programs, for the pregnant and lactating women who are also enrolled in our programs. Yeah.
Wow, sorry, seems Wangari has lost us. Can you hear me now? Oh, sorry, I was on mute. Okay. Yes, I was just asking, there is one question that has continued to be asked, how we integrate water, sanitation, and hygiene in nutrition programming. So Wangari, can you just take it up on how you've included WASH in the programming?
All right. How did we include WASH? Wow, there are different ways you can integrate WASH into the nutrition. There is at the household level. So at the household level, it's just to be able to, when the community is fetching water, we know that they are, the sources of water may not be clean. So it's to be able to provide them with what they need to be able to make the water, water that could be drunk, so drinkable water, for lack of a better word. So what we did is that we distributed what is called Aquatab. In Nairobi, if you go to the shops, they have small blue bottles that is called water guard. They tell you that put in X 1 drop or 2 drops in a 20-liter jerry can, for example. And that is meant to further improve the quality of the water at the household level. In some places, you can also add on soap. So that then when you're educating people about why they are getting diarrhea, is to let them know that they need to wash their hands. But then in Ileret or Marsabit, the biggest setback was the water was so little. So not only are you trying to improve it at a lot lower level within the household in terms of the access to quality drinking water at the household level, but then we realized we needed to go a step further. And that was what was my plea in this webinar to donors, that when the water sources, because the levels have been depleted, so even some of the boreholes were dry. Some of the boreholes, the water is too salty. So yes, there's water, it's running water, but I can't drink it. So for us, what we have done as MSF is then now we have added on a component of further increasing access to clean drinking water through the drilling of boreholes.
Thank you, Wangari. Thank you to the speakers. Thank you for that insightful talk on malnutrition. I think I don't think there's any question that we've not answered. If there's any that has remained, we will maybe answer them in the chat later, because for sure, our time is up. Thank you so much, our online audience, for joining, even for the interest to learn more about malnutrition. For sure, it's a crisis that needs to end, and for sure it has to be, it will need a collective action from different actors to be concluded. Yeah, thank you so much for listening. Thank you for listening to us. And just a request, if you can follow MSF on MSF Eastern Africa social media sites. So on Twitter, we are at MSF East Africa. On Facebook, MSF Eastern Africa. On YouTube, we are MSF Eastern Africa. And then on LinkedIn, we are Médecins Sans Frontières or the Doctors Without Borders, Eastern Africa. So if you want to follow more on our events and other activities, you can look us on our website, on our social media sites, which you can all hear or see on our digital platforms. Thank you all, and it was great having you all. Bye. Thank you, everyone.
Bye-bye.
Bye-bye. Thank you.